So here is a little cartoon to kind of give you an idea of how we can envision or predict the number of incorrect results that would be produced because of the existence of an out-of-control condition. So this horizontal line is our process, and each little vertical line is a patient specimen being tested, and the diamond is a quality control point. If it gives us the green light, we say life is good, and we keep marching on. You know, life is good. And then all of a sudden, a failure mode occurs, causes an out-of-control condition. The process is shifted. And now because, depending on the magnitude of that out-of-control condition, there's an increased likelihood of producing results that are incorrect. The incorrect results are denoted here with the little red asterisk above them. What fraction of patient samples have a red asterisk depends upon how big the out-of-control condition is. Now here, we're out of control, we get our next scheduled QC and it passes. Our QC procedures aren't perfect. We have power functions that show us that, you know, for certain size out-of-control conditions, we have less than a 100% chance of detecting them. Depends on the magnitude of the error again. So, oops, we didn't detect it the first time, so we're still generating all of these results are being affected by that condition. They're not all incorrect, but they're all being affected by it. Eventually, our QC rule rejects. We discovered that we had a problem. Then we do our troubleshooting, we figure out what the problem was, we run QC, we get the green light again, and then we keep marching on, okay? So the number of unreliable patient results produced, the number of red asterisks, is going to be a function of the magnitude of that out-of-control condition. The bigger the out-of-control condition, the more red asterisks. The power of the QC rule, how long did it take us to detect that problem? That's the detection part, right? And it's going to depend on the number of patient specimens between QC events. If I just increase the density of vertical lines between those QC events and maintain the same fraction that have a red asterisk above them, I'm going to increase the number of incorrect results, even though the power of my QC rule hasn't changed at all, right? So I denote this number of incorrect results as EN subscript U, expected number unreliable. It's the expected number of unreliable patient results generated during the existence of that out-of-control condition. So it's representing the number of red asterisks. And this is something we can compute. It's easy to compute. It's no more difficult to compute this than it is to compute a power function. So all of you that know how to compute power functions, you can do this too. So I'd say we have a lot we can say about P2 here. Given an out-of-control condition, how many incorrect results are generated? It's not going to be a P2. It's going to be the expected number of unacceptable results. What about P3? P3 is the probability that incorrect results that are generated will be reported. Well, the probability of reporting an unreliable patient result is going to depend on a number of things also. It's going to depend upon how and when results are reported, and it's going to depend upon how likely it is that you can identify and correct a reported unreliable result before an incorrect action is taken. So if I don't report a result that was incorrect, then I'm not going to cause a hazardous situation. If I report an incorrect result but recognize it and repeat it, correct it, and update it before it's likely that an incorrect action has occurred, then I've also prevented that hazardous situation. So in this ENU, in this span where we've got incorrect results, we can think of dividing it into two regions, what I call the pre and the post region, okay? And the idea here is that the results from the incorrect results that were produced from the inception of the out-of-control condition until the last good QC event, I call those are the ones prior to the last good QC event, and then there are those that are since the last good QC event until the time that I detect the error condition. I call the pre-final because my assumption is those results are out there and they're never going to be identified as incorrect and updated. They're final. If they created hazardous situations, and if harm results from that, that's just the case. The post, whether or not they create a hazardous situation, is going to depend upon how you report results and how you do troubleshooting after you detect a failure. So if you're doing what I refer to as bracketed QC, which means that you're testing your QCs, if they pass, you test patient specimens, but you hold them until you get your next QC event passing, and then you release all the results. In that case, those post results never get reported. They were incorrect results that were produced, but they never get reported. Okay. If you're immediately reporting results, when you get a QC event that passes and now you're testing patient specimens and you're immediately releasing them, then when you get your QC rule rejection, most guidelines say that it's your responsibility to investigate all of the patient specimens that you've reported since the last good QC event and try to do something about it. If you have a good process in place for doing that, and you can identify those and correct them in a timely fashion, then they also would not cause a hazardous situation. So I call that the correctable results. So this is the terminology I'm going to use here. Enough, I like to call it enough of those bad results. We don't want any more of those. That's EN subscript UF, and ENUC for shorthand. Expected number of unacceptable final results, expected number of unacceptable correctable results. Those two numbers just add up to the total number. And again, they're easy to compute, not hard to